Well, after that enlightening talk by Madeline, and Madeline's are always enlightening, we're going to have an equally enlightening talk, I'm sure, by Professor Charles Watson. Now, I asked Charles for a biography, and he sent me a couple of things that we thought if we had a bit of extra time, we could ask him to bring out his baritone saxophone, but I don't think he brought it with him.
Lucky.
Professor Charles Watson is a public health physician and specialist in the area of brain and spinal cord mapping. Graduated in medicine from the University of Sydney in 1967 and was awarded a research doctorate, MD, by University of New South Wales in 1974, lectured in anatomy between 70 and 82 at University of New South Wales, then took up a career in public health in the Health Department of WA and was Chief Health Officer for WA in 1993. Basically, he's been back in university life since '94, has published 11 books and over 30 articles, and one of his books, The Rat Brain in Stereotaxic Coordinates, has been cited over 60,000 times and is basically a world leading reference in neuroscience. He's also an author in The Control of Communicable Diseases, published in 2007. Professor Watson was made a member of the Order of Australia in 2004 and earned a Doctor of Science from the University of Sydney in 2012. And it says that in his spare time, he's he swims in the ocean, and an enthusiastic, but as he says, a mediocre player of the baritone saxophone. I'll give you Professor Charles Watson.
Thank you, Norm. Thanks for the opportunity to talk to you. I have to say that this particular presentation was originally developed by my wonderful friend and colleague Aileen Plant, who died some years ago. Aileen was the leading outbreak control specialist in Australia, without a doubt. Just a fantastic, not only a fantastic public health operator, but she had fantastic clinical skills from a time in Northern Territory. She was wonderful to work with, and the book which I published in 2007 on control of communicable disease is basically about 60% written by Aileen and about 40% written by me. She was fantastic friend and colleague, and so this is basically a talk of hers that I stole when it comes down to it. Now, emerging infectious diseases have become a hot topic over the last 15 to 20 years, and seems for a long while before that, before HIV, we never really heard of new infectious diseases. You know, there was TB and malaria and all the other normal bad things around the world, but increasingly since then, these things pop up for different reasons. Can you let me know one that's a sort of favourite or that you're particularly interested in? Tell me about your favourite emerging infectious diseases, new ones. Pardon? So, now, yeah, that's a very good idea. That's re-emerging. Yeah. So we have things for different reasons. Why do you think whooping cough is re-emerging? Yeah, because of basically inadequate vaccination. So there is an explanation for that, and that is that the community should be immune to that, but they're not. What's another one? So, SARS. Yeah. Oh, okay. I'm sorry, you missed out on that one, Jim. Thank you. Okay. SARS, the severe acute respiratory syndrome, and more recently MERS, the Middle East respiratory syndrome, which is a related virus that have occurred. Why did they pop up? They're actually new. I mean, they're viruses that existed in animals before, but we hadn't seen a set of human cases. Of course, you know, back before HIV, the monitoring and surveillance of infectious disease in Australia was at a pretty low level. I mean, one thing that HIV did for the country was set up decent surveillance systems, which have been operating really well since then, and a national committee that monitors all these sorts of things and so on. So these were actually new. And when you look at all the various ones, we'll look at the table of them in just a little while, you can see that quite a lot of them are new. That is, to the extent that we didn't know about them before and they popped out, and hence they show things. And of course, they always reveal interesting and different things. The Middle Eastern respiratory syndrome that's present in Saudi Arabia at the moment hasn't infected an awful lot of people, around about 100, but the death rate is quite high. And people found that it's the same virus, the coronavirus, that is present in bats in caves around the edge of the ocean there, and wondered how humans got it. They think that now the camels get it from bats because they breed in the virus in the caves, and then the camels pass it on to humans. But it always takes a bit of sorting out. I mean, SARS was very tricky to sort out. It was actually not so hard to control because once you found out how it was transmitted through fecal oral transfer and aerosol as well, and you basically, as Aileen said to me when she went to Vietnam to control the SARS outbreak there, she said, look, it's pretty simple really. You find all the people that are sick and you isolate them, and you find all the people that they were in contact with and you isolate them, and that's kind of it. And when you're in Vietnam with a command government system in the communist way, she said it was fantastic. She just met with the junior health minister every morning, had a list of what she wanted done, close this hospital, move these people there and that, and was all done by lunchtime. So it was the first part of the SARS epidemic under control. But what was interesting, that's the stage, of course, didn't really know where it came from and weren't exactly sure about transmission and so on. Give me another one. Legionnaires, yeah, right. It was Legionella. It was, of course, it was new and a fantastic detective story about how these people started getting ill with this thing. Someone realised that they'd all been at it's like an RSL conference in Philadelphia. They'd all been in the same place. It took a while for them to tumble to that, and then they realised that it comes from the air conditioning system and so on like that. So we could go on listing a variety of these, and some of them are things which were probably around but not well known before, and there are some genuinely new things that pop out from every so often. I mean, HIV was a classic like that, and we never had any idea that there was any such virus. Luckily, there's been a lot of research funded on that group of viruses prior to that by the American administration, because they had this sort of one of these, we'll go to the moon projects. It was We'll Conquer Cancer, and they funded everything to do with cancer for about 5 years. And amongst it was those viruses which turned out to be HIV. So they had a head start when they actually found the virus. But it's a tricky business, and so we'll look now at a little slightly more systematic rundown through the things that are there as we get through some slides. The strict definition is from the Institute of Medicine in the United States. It's disease of infectious origin whose incidence in humans has increased within the past 2 decades or threatens to increase in the near future because of early signs of such an increase, which is fair enough. It's, in other words, a pretty obvious thing. And that, of course, will include diseases like whooping cough that we thought we had nicely under control and have then started to re-emerge in some populations. So that's a classic for that. And the other ones will be diseases that we hadn't heard of before that have popped out. And these are some of the ones that we might run down. And each one of these tends to tell a different story. Just to pick on a couple of them. I mean, Helicobacter pylori had obviously been around for a long while, causing duodenal ulcers and such like, but no one had actually identified the bacterium. And so the disease actually didn't emerge suddenly, but the knowledge about the infectious agent was suddenly an interesting one. Hendra virus and Australia bat lyssavirus are interesting because about the middle 90s, it was realised that bats carried a large number of rather nasty viruses which didn't seem to affect the bats very much, but which were transmitted to humans. And the Hendra virus, which is similar to the Nipah virus, which caused an outbreak just a little before that in Malaysia. The Nipah virus outbreak spread through pigs mostly. They had to, in fact, wipe out the national herd to replace it with a new set of pigs. And about 105 people died from that. In Australia, it affected some horses, and a famous horse trainer, Vic Rail, died of it. And they were still getting cases and deaths around about every August, I think it is August, September, every year since then. And of course, the Australian bat lyssavirus is an interesting thing. There were 2 people died in Australia from being scratched or bitten, one by one of the small insectivorous bats and one by a flying fox. back around that time. And until then, Australia had been completely in denial about the existence of rabies-type virus, and they carefully call it Australia bat lyssavirus, so they don't mention the word rabies because they don't like that. There are actually 6 lyssaviruses. One is classical rabies virus, and this is just as dangerous as classical rabies virus. It just happens to have been given a different name, and so it makes people think we haven't got rabies. And of course, the whole variant CJD mad cow disease story is one that we could talk about for 2 hours. Just an amazing thing where a disease which had been present in sheep called scrapie transmitted to cows and then to humans, and they realised it was essentially the same disease as a sporadic disease called variant CJD. And of course wasn't caused by a virus, but by this rogue protein, the prion agent. So that was an enormous sort of lurch in terms of our understanding of all those things. I just realised they have got Nipah virus just down there. Of course, it's good to put down swine flu to remind us that of the really important emerging infectious disease over the last 100 years, the influenza outbreaks top everything. I mean, the one that followed the First World War is said to have killed more people than the First World War did. I mean, my grandfather used to say that every family that he knew in Sydney had someone die of influenza during that period. It was a really incredible massacre. And then we had Asian flu in the early 60s thereabouts, and swine flu turned out not to be a massive, killer or whatever, but there was a lot of worry about it, and there's still a lot of worry about the possibility of avian flus coming through, because although the likelihood of them getting into human populations in a big way seems low, they are devastating. They don't just give you an influenza-like illness, they basically just cause massive organ failure in 24 to 48 hours and you die. They're really incredibly vicious viruses that are there. So this is a motley group of things. We've even said here, some of these are old disease re-emerging, some of them seem new, some of them were bacteria that we found from around the place. So can we look at the underlying causes a little bit? Basically, can break them down into 4 headings, although there's some overlap between the times here, and that is changes in the organism themselves, host factors, immunity and so on, transmission factors, and broader environmental factors that are there. The organism factors, changing virulence and changing relationship between the hosts and changing I'm jumping ahead of this, changing resistance to the treatment methods that we have. I mean, TB really should have been controlled a long while ago if we'd used the drugs properly that we had then, but we didn't, and we've allowed resistance to all of the various organisms to continue to emerge, and it's and it is still, in a sense, an emerging infectious disease worldwide, and it could be worse. Changing virulence is that, like amongst the influenza viruses, that you can have influenza viruses that seem to get on happily with ducks and other birds and pigs in China, and then one of them becomes more virulent, spreads to humans, and spreads out from there in the standard sort of way. The host factors are a number of them. On the good side, improved living standards have made a lot of difference to lowering the likelihood of infectious disease. You know, recently there was an outbreak of toxigenic E. coli at the show in Brisbane, which they quaintly call the ECA, because it used to be called the exhibition in the beginning. Apparently, it's a weird thing. But basically, people who went to the petting zoo got the virus, got the bacterium, this toxigenic E. coli, and it spread. Now, E. coli spreads incredibly easily. I mean, you need like one particle. So the important way to deal with it is good hand washing is absolutely fine. That stops the possibility, but you don't need very much. And from those 4 original cases there, I think they have 30 confirmed, and they're investigating another 60. And the reason that it doesn't happen more often in Australia is that we have pretty good standards of personal hygiene. We have good sewerage systems. We have water available to wash hands, and so on and so on. And so we are protected from a lot of illnesses. The other one that's just happened in Queensland is they've had an outbreak of norovirus. it's an odd thing, you know. They used to call this Norwalk agent or Norwalk virus, named after the city in New Jersey where it first arose, and apparently strictly calling them norovirus outbreaks is not actually technically the best way. You still should call it Norwalk virus or Norwalk agent for obscure technical reasons that only virologists would probably understand. But it's interesting because, you know, throughout the world, it's the most common cause of diarrhea. And amazingly, we don't have that many outbreaks here. They happen in places where people are confined in one situation, like cruise ships. Whenever you hear there's an outbreak on a cruise ship, it's always Norwalk agent doing that sort of thing, or at camps or other things where they're enclosed together. But one of the new findings about Norwalk agent, there was a review of some cases in a restaurant in the United States, and someone with the disease, and this might put you off your lunch, but vomited very violently, and what happened was that the aerosol created from the vomitus infected people not only at the same table but on the other side of the restaurant, and that's really gives you cause for thought, and it shows how easily it's transmitted, and therefore that it's amazing that our available hygiene systems actually contain it most of the time. It's a pretty good indication that we have a pretty reasonable system. Then, relating to exactly what we're talking about here, we have some diseases that re-emerge because our immunisation of some groups is not effective, and of course some other infections became apparent in cases of immunodeficiency, so that pneumocystis pneumonia and a variety of other strange infections emerged in these groups for just that reason. Having an ageing population is another effect. A lot of infectious diseases hit older people harder, just as they hit babies harder. So you often get, like with E. coli, toxigenic E. coli outbreaks, that they tend to affect one end of the scale or the other. There are transmission factors, and this is a sort of bit of a random collection of things that have become apparent over the past 30 years or so. But international plane travel makes it possible to have diseases spread very rapidly. And SARS, you know, was started off in Hong Kong, essentially, quickly spread to Canada and Vietnam and all over the place. And the MERS, the Middle East respiratory syndrome, popped up by people travelling back to Europe, to France and United Kingdom. The guy in France, I think, infected someone in the bed next to him, of course, and it got transmitted in that way. And of course, with injecting drug use, organ transplantation, blood transfusions, all carry a risk of transmitting structures which are in the blood, which, you know, in the olden days didn't happen because none of those things were prominent ways of exchanging body fluids between people. And then, of course, indwelling catheters and hospital settings in general create all sorts of opportunities for transmission, which we would never have thought of before. They're continuing to go. And the other is not only new ways in which food is stored and processed, but also new food tastes. The outbreak of what I'm just trying to think of, the bacterium that's I've just lost it from my mind for the moment, that's present in food and lasts through the refrigerator. Listeria, thank you. I managed the outbreak. I should know about what was going on with it. We'd never seen outbreaks of listeria before the 1980s, and this outbreak here, which was caused by some contamination in Normandy foods where they were making pate, got transmitted, and about 10 babies died from premature birth. It was pretty awful, and there have been similar outbreaks around Australia of listeria, and it seems that there are two big factors in it. One is that people have an appetite for what you call cru foods, rawer foods, pates and soft cheeses, and a variety of other foods that weren't really popular, back in the 1950s and 60s. People ate good old cheddar cheese and none of this French soft cheeses stuff, and had proper sausages instead of pate and that kind of thing. But we eat a lot of foods of that kind now. And so there's an exposure thing. And the second thing that people didn't realize is listeria grows in the fridge at 4 degrees centigrade. It grows slowly, but it does grow. And so normally the fridge is, the guarantee that everything's okay. You put stuff in the fridge, nothing's going to happen. Well, it does happen. And you can get a decent dose of the stuff that is transmitted in that way. There are, another classic of that kind that you may remember from the 1990s was the aeroplane orange juice transmission. Basically what happened was that the company that made the little things of orange juice for the airline companies in the early 90s had some transmission with norovirus, it was, actually, it was not surprising, in their line, and people were getting sick all around Australia. And it's quite interesting, this often happens in infectious disease outbreaks, is that one particular group of people helps to identify it. And in this case, it was the North Melbourne football team. They flew to play in Sydney, and they flew back again. And some of them didn't fly back. They decided just to drive back with their mates. And on Tuesday, all of those that had flown back didn't turn up for training. And the ones who'd driven back turned up for training, and something clicked, and they worked out what the issue was. But it was it provoked a lot of interesting things. I mean, there's some awful stories. One of a very loving grandmother who was going down to see her children in Tasmania. So she flew from, I think, Cairns to Brisbane, Brisbane to Sydney, Sydney to Melbourne, and Melbourne to Hobart on cheap flights. And she collected all the orange juices that they gave her all the way and gave them out to her 3 little grandchildren when she got there. And they all got incredibly ill. There was another story of a poor man who'd flown from Sydney to Perth to have a holiday with his mates over here. And he got so ill, he was admitted to Royal Perth Hospital. They didn't really know what the problem was, but that as soon as he was well enough to get out of bed, they sent him back to Sydney, where because he was low on fluids, he really dosed up on the orange juice. By the time he got to Sydney, he was almost moribund. These are things which globalization of food supplies invoke a whole lot of risks that we never really thought about before that. But one favourite of mine is the chicken contamination story. Some people who were attending a restaurant in Juneau, Alaska, became ill after eating there, and oddly enough, it was the vegetarians who were there and not the people that ate the fried chicken, which was the main product of the restaurant was there. What it turned out, it was the chickens, and as they tracked it back, a contamination of fish meal in Venezuela was the original cause with this salmonella. That was shipped to Mississippi where they were growing the chickens. The chickens were fed that, they became infected. The chickens were then sent off, frozen off to Juneau, Alaska. And when they prepared the chickens, they chopped them up and put them in the deep fryer, and then they prepared the salads on the same plate as they prepared the chickens. So the nice sort of pro-animal vegetarians all got the illness, and the people who ate fried chicken and chips didn't, which was kind of an odd thing to do with it. So there are those sort of cases that occur all the time too. That's right. There are environmental factors. Population changes, developed demographic shifts. I mean, a huge one which has been occurring in the last 20 years has, of course, been what's happening within China. There's a huge middle class in China who want to live as well as their Western counterparts. And in China, one of the classic sayings is that there cannot be a feast without a chicken. If you have a proper meal of some kind, you have to have at least one chicken on the table. So the chicken production in China is just at a level you couldn't possibly believe. It is just absolutely massive. And the control in many of these places is not that good. And it's really a time bomb waiting to happen in terms of lack of control of the spread of illnesses through there. There are climate change issues. Oh, no, sorry, we'll go back to that. There's no doubt that we're already seeing changes in some of the vectors, movement of mosquito populations around the place. I mean, one's got to be a little careful not to overinterpret this. There have in the historical past been shifts in vectors like Aedes mosquitoes. There was one point about 40 years ago when they came down nearly as far as Sydney, and then they disappeared back up again and became restricted to the north in the same way as they have before. But we are seeing changes, and we will see a lot more. There's no doubt of that. And of course, what's happening in our hospitals is another area. The new kinds of surgical operations, lengths of stay, and so on and so on. And of course, the sleeper in all of this is the antibiotic use, which is generating its own versions of different threatening infectious diseases. One of the things to say is that most of the emerging infectious diseases are ones that actually keep on popping up in animals, and we don't see the results of most of that until they happen to get transmitted to us. And so, so it says here that 80% of all the new EIDs in human cases come from animal-based diseases. SARS is a classic example of that, which I don't know if they're exactly sure, but it's said that it was civet cats. There are probably bats actually as well that had the organism that's there. And in ordinary life, most organisms stick to just one species or a limited number of species. That the MERS, for example, it seems as they track it back, was probably present in one species of bats in the Middle East that lives in caves around there, and it probably had been that way for an awfully long while, and then it just happens to have spread out from there. And it may be that they changed virulence, or it may be that camels were looking for more places to drink water and they went into caves to do that. You know, all sorts of things affected. And as I said, most of these crossovers actually don't lead to further spread. And MERS is a little bit like that. While there has been some small further spread, it's been to very close contacts, and there have been very few of them. I mean, there's been about one, I think an average of one secondary case for every primary case. So, you know, it's nothing like what's happening with SARS, for example. However, there are always exceptions, and influenza is the exception for all of these because it has the ability to cross over and spread very rapidly in humans because it's such an enterprising virus with the ability to continually shuffle all of its antigens and produce new versions. And I think we've talked about all of these. Oh, just to mention, Nipah is as I said before, is the name for the outbreak which happened in Malaysia, which probably came from bats and got into the pigs and then killed humans as well. And it's probably the same virus as caused the Hendra virus outbreaks in Queensland. In relation to the bats, it's interesting that the populations of bats in Southeast Asia are essentially biologically continuous with the bats right down the east coast. So the bats fly backwards and forwards, infecting one another. So that anything that happens in one population of bats along it fairly quickly gets spread the whole way along it. Bats are unusual though. They do seem to have amazing resistance to some infections that like rabies, for example, that are quite. Now, bats do actually get sick from rabies, but many of these diseases, bats actually can tolerate for quite long periods of time. They're very unusual animals. I only realised recently, someone was pointing out to me that bats have a big place in the biological world. If you look at all the mammals in the world, whether you look at the numbers or the different species of them, half of them are rodents, right? And of the rest, half of them are bats. And we fit into the last quarter with all of the other lions and tigers and elephants and everything, and all the monkeys and us. But bats occupy a quarter of the space. There's just this almost infinite variety of different species of bats occupying different niches throughout the world. They have very unusual characteristics. So this is Aileen's summary of what are the kinds of things that are causing the things that are here. We've talked about a few of them already. They're societal events like movement of populations from one place to another and so on. I mean, when you look at what's happening currently in Syria, where a fifth of the population is currently left, I think it's something like 2.5 million are in camps and may never go back. I mean, have you seen some of those pictures of camps where these tents just go on as far as the horizon, the most amazing thing, and providing enormous challenges for international agencies in fact, I think it has to be said that international agencies that measure these huge forced migrations and such like actually do pretty well. I mean, you know, a lot of people don't die from the obvious things. They manage to get basic hygiene installed fairly early. They manage to monitor and keep things going reasonably well. The changes in the nature of healthcare and healthcare systems, food production, human behaviour. There's no doubt that the initial spread of HIV was male-to-male sex, which had not been recognised as being as widespread as it was before that time, and not been taken into account. Environmental changes, and of course adaptation to the microbes themselves, and whether or not you have a public health infrastructure or not. I must say, it does worry me a little bit about Queensland when they've had a whole series of infectious disease things happen there. You wonder if there's been some sort of dumbing down of the system that's there. I mean, I think that's probably a little bit cruel because the people there seem to be doing a good job. But I think if you look around Australia and you see a whole lot of outbreaks occurring at a particular spot, it can be quite often because the system just isn't strong enough. There's not enough people who are knowledgeable out there. The surveillance is not good enough. The reporting systems don't work, and they don't manage things as well as far as that's concerned. I'm just watching. I've done pretty well for time, haven't I? Yeah. Okay. This is just one of Aileen's slides on the rise and rise of chicken meat sales. This is numbers of chickens in Indonesia, and there was a spike and then a later spike going up there. In China, it's basically the same sort of thing has happened, except that it started around about the middle 1990s and it's just gone up and up and up. It's just at a fantastic rate. Yes? The fall. I was actually wondering. I was hoping you wouldn't ask that question. No, I almost certainly there was some economic adjustment over that time. That's possible. Yeah. It is. It's always interesting in economic terms. You know, they talk about when they look at markets. Markets rise and rise and rise, and then something or other happens, and they call that a correction in the market, and then it sort of builds up again. And there's a wonderful novel that came out about 8 or 9 years ago called The Corrections, and it's not about markets. It's about a family where the family undergoes these things, and then there are corrections every so often in it by a guy called Franzine. If you ever see it, fantastic novel. But it's The Corrections. I always like the idea. And lastly, okay. So the big thing about emerging infectious diseases is an awareness of the fact that they're there, that preventing bad things happening depends almost entirely on our hygiene systems and systems of infection control. And, you know, if the systems within our hospitals and within our healthcare settings and within our communities are maintained at a high level, we have enormous protection, and you know, and that's why we don't have norovirus outbreaks all over Australia all the time, for example. But they will occur, and what it requires when you do get an outbreak, and perhaps the E. coli, toxigenic E. coli in Queensland is a good example. You need a very sophisticated system to get in there and find out which it is, what strain it is, and what it responds to, and so on and so on. And so you do need a technical infrastructure that can actually get to work and do the job that you need in order to managing it. But as Aileen says, underlying it, when you look at these social and economic factors, I mean, the social factors relating to whooping cough, that you get people with hippie left-wing leanings in the community who believe that they don't need to be subject to the various requirements of a technological society, and decide that freedom for them means no vaccination and none of all these other things that doctors offer them and so on. Whereas in fact they're just freeloading on the fact that most of the other kids are vaccinated. That's the only reason they escape. But they are important societal factors, and economic factors come into these sorts of things all the time in the same way. Any questions? Yes.
Sorry, Steve, can we?
Oh, sorry. Yeah.
The societal and economic factors. Yeah. You were just talking about vaccination, which I think is fascinating. No one wants whooping cough back when it's come back. We want diphtheria back, and we want
measles.
Measles.
Yeah.
But when should one stop? Because we can invent a vaccination, when should we stop necessarily injecting? Some of them.
Look, it's a great question, and it's proved to be much more difficult to answer than we ever thought, because back in the mid-1990s, there was this enormous enthusiasm for the programs to eliminate polio, and it went really well. And we belong to the Western Pacific area, and polio was officially declared eradicated in the Western Pacific in about 2003 or 4, I think was the time, and they expected worldwide eradication to happen by 2005, and they were planning for the phasing out of the vaccine and so on. And it's turned out to be much more difficult to get rid of those last cases. And also, there have been other things that have sprung up, and they of course switched in most places from the Salk vaccine to the Sabin, from the Sabin vaccine, the oral vaccine, to the Salk type vaccine, mainly for commercial purposes. That the court cases relating to it cost an awful lot of money, and they didn't want to look bad, and that's, I think, the main reason they switched, to do with that. But there are no immediate prospects for phasing out polio vaccination, and it's the easiest. I mean, and one would think that was the one they could get on top of and then just start. But there's this terrible reluctance to do it, because what if they phased out all the vaccination and then some cases popped up somewhere or another? Wouldn't they be in trouble? And they would be in trouble very quickly. Mind you, in China, where the story of polio eradication is a very interesting one, they were working hard on their polio vaccination in the late 80s and early 90s, and finally China developed what is the killer strategy, and that is the National Immunisation Day, because they were immunising a group here and then another group here, another group here, and when they finished that, the ones that were around here infected those and sort of followed them around, so they couldn't ever catch up with it because it was re-emerging all the time. And National Immunisation Day attempted to vaccinate every child in a particular age group and thing, and after a couple of National Immunisation Days, they went from 20,000 paralytic polio cases a year down to 0, basically. It was a fantastic thing. It showed that you can make things happen like that. And when they got a couple of introduced cases, people coming from Nepal or somewhere like that came to Western China with the help of international agencies, admittedly. They in something like in 4 days, they vaccinated 5 million people around the original case, and then they vaccinated 25 more in the next week around that to completely enclose it and so on. So, it can be done. What I'm saying, retrospective management of it can be done if you didn't have a vaccine operative at the time. But I think it's going to be very tricky. I think that we'll probably be injecting more vaccines in our kids over time, as it goes on.
I suppose that was the question. Is there an economic answer to things like papilloviral ones, where it makes that makes sense, but the meningococcal vaccination is a very small proportion of people get infected by it, but the cost of the vaccination is way beyond the return you get, and they keep inventing more and more because we can.
Yeah.
It's where do you draw the line? So you don't
look, it's a question which isn't dealt with seriously enough, and the enthusiasm for introducing a new vaccination is only really calculated out on a cost-benefit basis. I mean, I've always worried about the fact that we have routine hepatitis B vaccination for all children in the community, which was incredibly strongly touted by the vaccine manufacturers, who push really hard to get that done. Because when you actually look at the risk to most of the babies that are born in Australia, it's so unbelievably low. Now, that babies of Southeast Asian origin, with mothers of Southeast Asian origin, in Aboriginal communities where there are high levels of the viruses, absolutely important. But for the rest of the community, no. And this whole push that's been in some areas to vaccinate otherwise healthy adults is just complete stupidity. I mean, you know, and basically we're often left in the hands of a number of enthusiasts and a couple of health ministers say, oh, this would be a good policy to announce for the next election, and the meningococcal probably came in, you know, some of the meningococcal stuff like that. So you have a very, very expensive vaccination simply because the few cases of the disease that we might get are so horrific that we decide to go that way. So, you know, the problem is that the true economic evaluation of many of the strategies that we have really doesn't happen very often in our healthcare system. People come up with bright ideas, and if they're politically attractive, people run with them, and no one ever actually gets to say, how many lives could we have saved if we spent this on something else? I don't know if you've ever seen the book, but there's a wonderful health economics book by Fuchs from Stanford called Who Shall Live? It's a quotation from the Old Testament. And that's exactly his point, is that there is not enough money to do all the things we want in the healthcare system, to save all the people from illness and everything else. And so every time you spend something over here on something you didn't before, you're depriving some other people over here who will probably die prematurely, or their children will get ill or whatever. And that it's not, so you have to make judgments which are rational and carefully considered. Anyway, long answer to the question, I'm sorry. Did you have a question? Yeah. Yeah, look, the whole mask thing is an interesting one. I mean, SARS certainly provoked that. It turns out that the very high quality, aren't they sort of E95? Is that what? Yeah, masks are pretty effective, although not for an awfully long period of time. The ones that just go over the front of your mouth probably don't really do anything much at all. But there is some advantage from the good quality masks for a short period of time. One of the things I didn't realize when I went to Japan, I thought that all these people were wearing masks because they were afraid of catching bugs from the people around them. It's exactly the opposite. People in Japan are very aware that if they have the beginning of a cold or something, they have a responsibility not to infect other people. So if they go to work, they must wear a mask to not infect other people, and they're very rigorous about this. And that one would have to say that's something which is to be applauded, because I mean we have the problem where people are feeling a bit crook and they go to work and infect everyone else in the office, and they're all off weeks at a time, and it's a pretty common kind of thing. You know, soldier through, don't worry about it, and perhaps you forget to cough or sneeze into the handkerchief or things of that kind. But I think that mask use can be effective in short-term situations with the high-quality masks. Yeah. Okay. Any other questions? What's the future of antibiotics, as Madeline's asking? You know, will they bail us out into the future? I'm not an antibiotic specialist in any way, but my general reading is that the future of antibiotic development is getting to the stage where it's looking a bit bleak in a number of areas. You know, things are really getting to be pretty threadbare, where one by one resistance develops to all of the frontline antibiotics in a particular area, and you're left with some incredibly toxic cocktail of things that are left, or nothing at all. In some cases, there are cases where that's happened. So that, you know, the heady post-war days, I remember my father was a GP, and he said that the only time he'd ever seen a lot of people actually discharged from major hospitals out of the community happened with penicillin for patients in mental hospitals, because they had syphilis and GPI, and they all got under penicillin, and their symptoms reduced, and they were all discharged in the community. Thousands of them, you know. It was really a major event. And so that, you know, when penicillin first came in, it was fantastic for gonorrhea and syphilis and everything that you gave anyone who had anything, you gave them penicillin, they just got better. And then that stopped happening and progressively resistance to penicillin occurs. And of course, despite the continual invention of new groups of antibiotics or variants of those antibiotics, it just we're getting more and more constrained about what the future is. I think that there's got to be a lot more sensible attention paid to strategies which don't maximise the use of antibiotics, so other alternatives, and very, very controlled use. And of course, you know, that one of the worst areas is the relatively uncontrolled use of antibiotics in agricultural settings, where there's an awful lot of stuff circulating. It's one little story that doesn't affect us, but that happened was that in India they started giving some new antibiotic to cows, which protected them from gastrointestinal illness or something or other like that, and it didn't seem to have any bad effect on the cows. And then people noticed that the kites, which are the vultures in India, were just dying like flies. And what had happened was that when animals die in India, the kites pick off the stuff. They're basically the cleaning system for dead animals around the whole of the countryside. And I think within a year, the population was reduced to about 5 or 10%. And I don't know whether it's recovered since, but that was the last I read. It was a pretty awful situation. Just happened this particular molecule was incredibly toxic to these birds. They just had to eat some little bits of scraps of meat from these animals, and they died. Yeah. Can I thank you very much for listening? I wish you well with your infectious disease control efforts. I mean, I think we're very fortunate in Western Australia to have in hospital and community-based health services a well-educated workforce that knows what they're doing, that are competent in doing the stuff, and that's why we sit in a situation where bad things don't happen very often at all. We really are enormously well protected here, and so thank all of you for the great work that you do. Thank you. Thank you very much. Oh, wow, my favourite thing.
That's very good.
Yeah, but red and white.
Usually is well accepted.
Thanks,
Charles. Just one point, and it's something I remember during Madeleine's talk.
Yeah.
She talked about the fear,
Yeah.
early fear. And interesting you talk about the bats. I read an article just recently about the MERS,
Yes.
and how the date sales in a lot of the rural markets have
really?
dropped right off because they theorized that the bats were actually defecating on the dates, and nobody bought dates. So the date sales just dropped tremendously.
All they would have had to do was just wash them.
Yeah, and they were because they really just didn't know. Ignorance and fear. Yeah. So thanks very much for very entertaining talk.
Thank you.
Very much.
Thanks.